And welcome back to the program. This half hour, we're featuring conversation with Dr. Francis Esguerra. He is a specialist in robotic surgery for pelvic disorders, but also an OBGYN. And welcome to the program. Sure appreciate you being here.
Lee, thank you so much for having me. Happy Saturday.
Thank you very much. How many babies will you deliver this year?
This year, I think I'm on pace to deliver about 250 babies.
Wow. You're a busy guy.
Well, I love what I do. I'm living the dream, and all I can say is every day, almost every day is a birthday for me. So I love eating some cake.
So what do you know about the changing in trends with childbirth? What are you seeing?
Right now, we're seeing a lot of move towards less intervention, and that can be great. You know, sometimes we have to get out of the body's way as far as letting the mothers go into labor and let their labor take its course.
And what does that mean in terms of getting out of the way and let labor happen?
Sometimes less intervention is more, and also watching and waiting. I was involved with a study at University of Michigan where if there was a failure to progress as far as a woman's labor, and we waited an extra hour, 75% of those women would continue to deliver vaginally.
Ah, so we're not jumping to other means.
Absolutely.
Let it happen.
Absolutely.
I get it. Okay.
And sometimes you just have to be a little patient. And I think that comes with experience, that comes with age. Not every labor will follow the textbook. Let's just put it that way.
Yeah, interesting. One of the things that I did in preparation for the program today was to take a look at what are women searching for in terms of women's health issues. And I was surprised to see that HPV is at the top of the list, human papillomavirus. Let's talk about how that is showing up in your practice. I'm sure you're advocating vaccine, right?
Absolutely. Yeah, HPV, there are certain high-risk strains, 16, 18, 33, 35, and there are vaccines to help guard against that. They're actually called Gardasil. And what they do is they prevent a certain type of cervical cancer that's associated with those forms of HPV. If you follow the guidelines, it's a 3-dose regimen for that vaccine. You can actually prevent that one form of cancer for the rest of your life.
That's amazing, isn't it, that we can prevent cancer
Absolutely.
with a vaccine? That's great. And men need to have this vaccine as well?
Yes, 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 recommended. So for women, it's recommended on ages 9 to 45. And then for men, it's, I think, the same age range. I think it's 9 to 26 at this point.
So we've kind of done a shotgun approach here. We're going to do that one more step. The other thing that I noticed in search results and what people are concerned about is increasing numbers of sexually transmitted diseases. Gonorrhea, chlamydia are on the rise in the United States. That's kind of a surprise to me.
Yeah, it is. It was a surprise to me, too. When I entered private practice in 2012, what I noticed was that there was a higher rate of sexually transmitted diseases and infections in the elderly population. You're talking typically the age of 60s and on up. What we found is the nursing home population has been essentially a cohort where you've had a rise in sexually transmitted infections over the past 5-10 years or so. In
sexual activity in nursing homes where
yes,
condoms
sir.
are not readily available. And
yes, sir.
Wow. Well, who knew, right?
It's almost like they're back in college. It's like they're back in the dorms.
Yeah, how about that? 2.4 million infections last year was the number reported. That's really remarkable. Okay, so those are the broad topics, but I want to get more focused on a couple of other things. What's really new in your field of OBGYN?
Well, I would say there's a move towards minimally invasive surgery. What I specialize in as well is going to be robotic surgery. So we actually use a machine called the Da Vinci robot. It's an instrument made by Intuitive, and it allows us to almost have 2 to 4 small hands or small instruments inside the abdomen and inside the pelvis.
And so I'm fascinated by that. This thing has been around for quite a while.
Yes, sir. Absolutely.
But the advantage to you is that it's fine control, right? Very, very fine control of the instruments?
Yeah, it takes away any tremor. But more importantly, it's the camera. It's almost like I have a front row seat in someone's pelvis. It's HD, so it's high definition. It's 1080p, so it's the highest definition you could possibly get on any type of video. And it's also 3D. So it's the world's probably most expensive Xbox.
So what are the conditions that you're going to be using that for? I'm assuming uterine fibroid tumors?
Yep, uterine fibroid tumors, so we can remove that. That's called the laparoscopic or Da Vinci-assisted myomectomy. We can also take out a uterus, a hysterectomy, any type of pelvic masses. If a patient would need any type of lymph node dissection, we can also do that through there as if they had a cancer case. If they had anything as far as any pelvic floor prolapse, you can also repair that doing different fixations of the sacrospinous ligaments, and it works out great.
So I'm going to go back and touch on a few of those things. The fibroid problem is one that is pretty significant. So
absolutely,
fibroid tumors are not cancerous at all. It's essentially muscle tissue that's gone kind of out of whack and has either attached itself to the inside or the midlining of the uterus.
Yes.
It can be in many different ways. Typically, as I recall, it's predominant in women in their 30s and 40s. Is that right?
Absolutely, absolutely. It's a benign, smooth muscle tumor. The actual medical term we use is called leiomyoma, and the plural is going to be leiomyomata.
Okay.
So the reason why I know that is because when we study for our boards, they don't want us to say fibroids.
Oh, really? How come?
No, they want us to use the technical terms.
Oh, all right.
So if you say fibroid, they're like, are you sure that's what you want to say? And automatically go back to leiomyoma. But going back to it, it's a benign, smooth muscle tumor. Think of it as, a group of cells that just kind of lost their track, started growing. And they, the growth can be slow, but it can also be fairly quick. So you always look at it, but you look at the problems. When you look at problems that fibroids cause, typically it's going to be pelvic pain, bleeding, irregular periods, and a pelvic mass. They can sometimes grow. The biggest one I took out was about 47 pounds.
What?
47 pounds, yeah. Absolutely.
Oh, my Lord.
Now, I did not do that one through the small incisions.
Well, no,
I couldn't do that one. That was a big pelvic case.
So what are the symptoms that somebody's going to come? You described the pain and the bleeding and that kind of thing. How long has that gone on before somebody comes to see you for diagnosis?
It's different for each patient, but I would say probably on the order of about like 6 months. Most time, if people have a heavy period once, twice, they think, you know what, maybe it'll go away. Maybe they'll talk to their friends and start taking some things like ibuprofen to help decrease the bleeding. But then if they start having bloating, some pain, if it keeps on going for a little bit longer, then they typically come and see me for that.
And tell me about that process. So you do an evaluation. How do you identify that there are is it a physical visual examination? Yeah,
so you do a history and physical. So we ask them questions, do a physical exam where we do a pelvic exam with a speculum. That's what we would use to look inside the vagina. And we do a bimanual exam. Bimanual means one, you use 2 hands. So you have one hand in the vagina, one hand on the abdomen, and you're trying to palpate or feel where the uterus is, how big it is, and whether or not you can feel any masses. Along with the physical exam, you also do an ultrasound. Ultrasound can give you a lot of information as far as the location of the fibroid, if there might be something else as far as a polyp, and also any type of growth interval if you get multiple scans.
Is surgery always the answer?
No, not always. I think one of the marks of a great surgeon is knowing when to cut and when not to cut. Mm-hmm. Each patient is given options. You can always have options of expectant management where you watch and wait. Another one would be if you decide to try medical management. There are certain medicines that can actually try and shrink a fibroid or at least stop its growth.
Welcome back to the program. Dr. Francis Esguerra from Women's Health Advantage and I were just having a conversation that we're just not going to replay for those of you who weren't here during the commercial break. We were talking about menopause, another huge issue that you see commonly, I'm sure.
Absolutely. Yeah, menopause, average age of the change of life for menopause is going to be about 52 years old, and that's plus or minus about 4 years on average. So it can happen as soon as 48, as late as 56. Sometimes people even don't follow those, those rules and recommendations. They can sometimes even happen a little bit earlier. If you have the change of life happen before the age of 40, we call that premature ovarian failure. And I've had a couple patients, even late in their 50s, still having periods and not menopausal yet.
Hey, I wanted to just get a last-minute plug for the phones in here because it's a rare opportunity to speak with an OBGYN at no cost, no copay. And you do have to get into the gown, as we say on this program. So 447-1190 is the number to call if you are interested and have a question. 800-333-1190 is the toll-free. Back to menopause.
Yes.
Very controversial. The Women's Health Initiative study told us that we probably ought not to be using hormone therapy because of an increased risk of breast cancer. We put that aside now. We now believe that's no longer valid, right?
Well, you look at the evidence. You have to look at the whole study of the Women's Health Initiative. They never really took out anything in regards to family medical history. Another thing is when they look at increased risk of stroke and also blood clot in the legs and the lungs as far as with those individuals taking hormones, they didn't stratify any other risk, meaning smoking, diabetes, morbid obesity. So what we found from the Women's Health Initiative is that hormones can be very helpful in treatment of menopausal symptoms, mainly hot flashes, vaginal dryness, and mood swings. But we also have the information we extrapolated from that, and the recommendation to put you on the lowest dose possible for the shortest amount of time.
And you do not support bioidenticals.
Great question. If you look at the efficacy of bioidentical hormones,
let me back up a second and explain.
Sure.
There's two forms of hormone therapy. There is pharmaceuticals, drugs
synthetic
that you take, and then there are compounded bioidentical hormones that are usually plant-based estrogens. So
absolutely.
Now, with that said, tell me more about why your practice does not support bioidenticals.
Well, when you look at the medical evidence out there, the medical evidence shows that they're both going to be the same efficacy. One is not better than the other. In fact, you actually have higher regulatory procedures around the pharmaceutical grade ones as opposed to the plant-based. The reason for that is because when you have additives and you have different supplements along with the bioidenticals, they can be marketed as vitamins and supplements as opposed to hormonal treatment. So if you look at the American Board of OBGYN, they're the governing body that certifies all of us as far as for specialties. They actually have come up with a recommendation saying that they do not support the use of bioidentical hormones because they are not more efficacious than the pharmaceutical grade.
Okay, I guess that says that. Another condition that affects a lot of women, and often younger women, is PCOS.
Yes.
Polycystic ovary.
Absolutely.
And so let's talk about that a little bit.
Well, when you think about polycystic ovarian syndrome, it's going to be a myriad of symptoms. Typically, it's going to be something where they have irregular periods. They might not have any periods. They might have facial hair. They might have some issues with metabolic syndrome, meaning they might have an issue with insulin sensitivity and insulin resistance. But it's typically coupled with an endocrine dysfunction, endocrine meaning hormones in their body. So their ovaries are not functioning in conjunction with the rest of their body in a correct physiologic manner.
And so what's the preferred treatment?
Well, it depends. If you're going to treat the symptoms, typically it's going to be trying to regulate the hormones. So you might put them on a combined oral contraceptive pill to help regulate their periods, because we want their periods to be regular, light, and tolerable as far as pain. Mm-hmm. Another thing is if they tend to have other symptoms like facial hair, we can treat that also with the pill, which is the birth control pill, but also some other medications that would help block their free testosterone, which would be the functioning level of testosterone in their bodies. If they're looking to conceive, there's like a couple of different things we would also do. Sometimes we put them on metformin. Metformin is a medication that will help regulate their blood sugar. Mm-hmm. And also another medication called Clomid. Clomid is something that will help a woman not only ovulate, but typically superovulate. So that way they can get away from those cycles where they're not ovulating due to the PCOS or the polycystic ovarian syndrome.
And what about the discomfort that comes with PCOS?
When you look at the size of the ovaries, when a patient is placed on the birth control pill, what will happen is they will stop ovulating. So it'll inhibit ovulation and inhibit formation of those cysts. So over time, that should go away.
Okay. So if I have PCOS, a successful pregnancy is still very possible?
Very much so, yes.
What do you think are some myths or things that people don't understand about the OBGYN world?
Oh, my. Well, I would say that...
I mean, once you guys get together, what do you guys talk about?
Well, honestly, what a gift it is. What a gift the specialty is. It's a great mix. When I first went to medical school, I thought I was going to be a cardiologist or a gastroenterologist. And I did not think that OBGYN was even in my wheelhouse until I did it. I was a third-year medical student, and it was the most beautiful thing I've ever seen when I saw twins, being delivered. And I had never seen anything before. I was one of those uber masculine kind of guys, and tears were coming down my face. And it's a beautiful thing. It's a beautiful thing. It's a true gift. I think you can truly honor patients at two times. One would be when they're born. The other one is when they die. And to see births on a regular basis gives your whole sense of being a sense of optimism.
That's a lovely thought.
It is, and that's what I live every day.
Oh, that's neat. So when something goes wrong in pregnancy, mm-hmm. what is that most likely to be? Well,
it depends. Sometimes you can have preterm labor. Sometimes you can have hemorrhage or blood loss. You can sometimes have some issues with the baby itself. That is why we train. 95% of our training is going to be for 5% of the time. It's going to be for those emergencies, and that's why if there is an emergency, you want to be going to a place where they have, an OBGYN on staff 24/7. And that doesn't happen at every hospital.
Yeah, I was just reading that there's going to be a coming shortage of OBGYN guys.
Yes, sir.
And women. I keep saying guys. I meant that just generically as a group of physicians, as
Absolutely.
a specialty.
Right.
So if I'm not seeing an OBGYN during my pregnancy, if I'm having it managed by my family doctor, is there a problem with that?
No. And the reason why is because they are very capable of providing great obstetrical care. And, there's a certain threshold as far as whether your pregnancy will be low risk, moderate risk, or high risk. Kind of depends on your blood pressure issues, your prior medical history, if you had prior surgery, and things of that nature. Plus, there's also great options as well as midwives. With our group, we offer that option as well. We've got a great midwife in Andrea Yoder, and she does a wonderful job. She actually helped take care of my wife as well.
So what's going on in our community? We have a high rate of premature infant death. What's behind that? What's causing this?
Well, when you think about it, it's going to be there are a couple of different reasons. That's a huge multifactorial answer. First one would be access to health care. We need to get access to health care to everyone. Unfortunately, when you look at rural areas, the collection of OBGYNs per capita is relatively low. So then we have these centers where Fort Wayne would be one, but the service area is quite large. We even service Ohio and southern Michigan. So to get a pregnant mom to these areas can sometimes be pretty arduous. Then you have to think if there's an emergency where seconds matter and everything counts, sometimes we can't get that care, to them fast enough. And so sometimes it's not even enough to have an OBGYN on staff. We almost need to be closer to the patients.
And I would assume that is hitting our minority community at a higher rate.
Absolutely, which would require more education. If you look at how I started my career, I actually went out and talking to mothers of preschoolers at those MOPS groups that, kind of meet at churches.
Yeah.
I started meeting at those places talking about annual visits, preventative care, and then, prenatal and postpartum care.
We've got just a moment or so left. What's your closing thought? What do you want women to know that's most important, or maybe not paid enough attention to?
I think that there's a lot of attention paid towards the experience as far as labor and delivery. And what I would say is always make sure that you are given options, because I think that everyone has to understand that you have a choice. In your healthcare, there are risks, benefits, and alternatives to everything, but ultimately you are the one that makes the choice.
Give me an example of how that could be put into use.
Well, let's talk about medicine. Let's talk about medicine in general. If you are given a prescription for a medication, well, that's not the only medication that might work for you. You might have other options as well. You might have an option of using diet and exercise instead of medication and see if that works. It just kind of depends on the situation, but you always have options. And you always have the option of getting a second opinion as well.
I think that's good input. So that is Dr. Francis Esguerra, an MD, specializes in minimally invasive pelvic surgery, easier to say than for some others than me, at Women's Health Advantage, and you can find them online at heradvantage.com. This practice has 25 physicians and nurse practitioners offering care at 4 different locations. Again, you can find them online at heradvantage.com.